Good afternoon, everyone. My name is Bradley Coffey. I am the Government Affairs Manager here at the American Alliance of Orthopedic Executives. I want to take a minute to thank you for joining me for today's Capitol Hill Series webinar, Public Policy and You. I do have a few housekeeping notes to review, and then we'll get started with today's presentation. First of all, participants have audio access during the webinar. This means that you are able to listen to the presenters, but you cannot speak to them or to other attendees. A link to the handouts for this presentation can be found in the handout drop-down menu on the right side of your screen. And your questions are absolutely welcome on this webinar. If you have any questions, please type them into the chat box in the bottom right side of your screen. I will take time to address questions at the end of this presentation. The webinar will be uploaded to the AAOE Live Learning Center within 1 week for you to download and listen to again, or to share with your staff and physicians or anyone else at no additional charge. And in an effort to continuously improve our education, we ask that you participate in the survey that will be available following the webinar itself. So let's go ahead and jump right in. Today's webinar is called Public Policy and You. As I said before, I'm the Manager of Government Affairs here at the American Alliance of Orthopedic Executives. And as you can see, this is tied to our annual Capitol Hill Day in Washington, D.C., so there will be some references to that. So what is public policy? At its most basic level, public policy is what government chooses what to do or what not to do. Much like in economics, we are concerned with the distribution of scarce resources, except in this case, it's to achieve the goals of the state. Now, historically, the goals of the state have really been limited to issues like providing for the common defense. It was really at the turn of the 20th century that we started to become more concerned with promoting the general welfare. Now, you may remember those coming from the United States Constitution, the preamble to that document. So what does this mean? This means that at the turn of the 20th century, government started to become more and more active in the lives of its citizens. And that's what brings us here today. Public policy is created at the federal, state, tribal, county, and municipal levels. This fact really threw me. There are over 87,000 governments in the United States. To me, that's shocking, even though I studied this in graduate school. You never think about 87,000 governments operating within the United States. And again, all of these are from the federal government all the way down to your very most basic municipal government. And while our discussion will focus on federal policymaking, it is important to understand that your practice may be affected by something like a provider licensing law passed by your legislature or a zoning ordinance passed by your city or county government. In healthcare, federal law is not the end-all, be-all. Contrary to popular belief and schoolhouse rock, Congress is not the only branch of government that engages in policymaking. Congress does pass legislation that becomes the law if signed by the president, but the president does engage in policymaking as well in the form of regulations. These are really the bane of every public policy analyst's life. Regulations are some of the most difficult things to understand and comprehend. However, they are an interpretation and creation of federal statute and public policy. Even the judicial branch engages in policymaking through its power of judicial review. This would be having the power to declare a law unconstitutional. Good example, and also a very rare example of policy creation at the court would be the 1973 decision in Roe versus Wade, the abortion law or the abortion ruling that many people are familiar with. So this was actually a policy solution created by the Supreme Court, and it's something that the court has had to deal with ever since. Whether you are pro-abortion rights or anti-abortion rights, there is no doubt that this was a policy solution created by the court to try and solve a public policy problem. So policy is the output of institutions. Public policy is authoritatively determined, implemented, and enforced by the institutions of government, Congress, the executives, and the judiciary. Government lends legitimacy to public policies. Government policies are universal in that everyone in the society must abide by them, and government monopolizes the authority to imprison or penalize violators of the policy. If you just think about it, if the power of the government did not stand behind these policies, would you in fact follow them? I know there are many that I would prefer not to, but I don't want to be thrown in jail, so I do. Um, Policy is also a process. The policy process generally follows six main steps. You have problem identification. Legislators, interest groups, citizens identify a problem in which they need government action. The second step would be agenda setting. This is where the attention of mass media and public officials are drawn to the problem itself. Policy formulation would be the third step, and this is where policies to fix the problem are developed by interest groups, public officials, the public, and think tanks. The fourth step is policy legitimation. And this is the policy is given government legitimacy through government action on the policy. The next step would be policy implementation, so how government actually implements the policy itself. And finally, the government engages in what's known as policy evaluation. So the policy is evaluated by government agencies, such as the Government Accountability Office, the media, interest groups, think tanks, etc. And then the process starts all over again. So a good example of this would be the merit-based incentive payment system, which was created as a way to try and get rid of the Medicare sustainable growth rate. This was an issue that had been fought for about 18 years by the healthcare community to get rid of the SGR. And in 2015, MIPS was created as a solution to this, and the SGR went away. However, with MIPS has come a lot of issues. That's one thing that I should say. Anytime in public policy making, there are always issues that pop up after the legislation is actually enacted and begins to be implemented. So this policy evaluation process is very important because then that sets up the next cycle for policy making in order to correct some of the unintended consequences that came out of the first policy making. So the next thing that policy is it's rational. Government chooses policies that result in the greatest gains to society. The gains to society must exceed costs by the greatest amount. So, for example, universal health care is a great idea, but to many, the costs outweigh the benefits to society. Now, this one is up for debate. It's something that Republicans and Democrats are currently debating, and I think will be a big feature in the 2018 midterms that we are coming up on in November. But that is a good example of how a rational policy plays out. It should note that there are always cases that disprove the rule. Some laws passed by Congress may not be considered rational by some, and others may view the same law as completely rational. This will be discussed further in this session, where we sort of talk about how people view particular policies themselves. Policy is also incremental. Dramatic shifts in policy are avoided and only incremental modifications to past government activities occur. Again, universal health care is a great idea, but the shock to the economy would be more than the market could bear. This is why we have something like the Affordable Care Act that passes. The Affordable Care Act was widely seen as a step towards universal health care by many in the policy community, but it was not a full step to universal health care. It was sort of a middle ground that policymakers created to ease us into that universal health care. So the next step is that policy is the outcome of a group equilibrium. So in this, policy is seen as the equilibrium reached between interest groups as they struggle among each other for influence and government action. So the best way to think about this is it's a compromise between warring groups. So anytime you have a policy make its way through Congress and onto the executive's desk, you can see that as a compromise piece of legislation. Very rarely do Republicans get everything that they want in legislation. Very rarely do Democrats get everything that they want in in legislation. And that's partly because of the structure of Congress. So as you may be aware, it takes 60 votes to get legislation through the Senate because of some Senate rules known as the filibuster. In order to end debate in the Senate, 60 senators have to vote in the majority. And very rarely do parties enjoy a supermajority in the Senate. It's typically where you have, 55 Republicans, 45 Democrats. So it's very difficult to get to that 60. So inevitably, any piece of legislation has to have some kind of compromise between the two parties. And the same would be said for interest groups. Very rarely do interest groups get everything that they want in a piece of legislation. AAOE ended up supporting repeal of the sustainable growth rate. We were not thrilled about MIPS and about the way that this would be set up. We thought it would be very complicated, and it turns out it is. But we felt that getting rid of the SGR was far more important, and we could change MIPS in a way, once it was implemented, that would benefit our membership. So we've gone over what policy is. So what is health public policy? So health public policy is arguably one of the most important policy fields in American government. And I don't say that just because we are a healthcare association and because I deal with health policy every day. I say that because 44% of all healthcare spending in the United States is paid for by the federal government. Healthcare spending in the U.S. makes up approximately 1/5 of the entire national economy. That is huge. I don't have the number in front of me, but the United States economy is worth trillions and trillions and trillions of dollars. And you think about all that healthcare spending is just 1/5 of that. Even though it's only 1/5, that's still a huge amount of dollars that we are spending on healthcare. And I would say that this is a subset of policy that will touch your work lives the most, but it will also touch your private lives as well. For example, however you feel about the Affordable Care Act, the increase in premiums is directly related to policymakers' decisions to weaken the law in Congress and the courts. This impacts not only your ability to access care by increasing the costs for your insurance, but it also increases the cost of health insurance for your patients, which can lead to fewer patients and lead to lower revenues for your practice. So healthcare policy is extremely important to the overall policy community, and it's extremely important to us as an association of healthcare administrators. So I want to take a minute and launch a poll real quick. And if you could just tell me, how do you view health policy of these two choices? We'll give that a couple seconds. Okay, so we have 50% says the U.S. has the best medical care system in the world, and 50% says the U.S. is the worst in healthcare among developed countries. Well, I'm happy to tell you that ultimately these are both true. There is not a wrong answer with this. I shouldn't say happy because I would love to be able to say that only one of those is true, ideally the first, but they are both true. So let's get into sort of why this is the case. The reason that healthcare in the U.S. is seen in these two distinct ways is because of two little words, fairness and efficiency, and how our policymakers have prioritized these values over the years, as well as how they view the entire concepts of fairness and efficiency as well. This conflicting valuation has led to, at times, a healthcare system that is full of contradictions. Disputes over health policy typically center around our interpretations of these two values. For example, the definition of efficiency is not universal. A physician's waiting room is efficient in terms of using the physician's time, However, as a patient, it is not efficient for me, who ends up spending a lot of time in the waiting room. Um, there is also a built-in tension between these two. To get the most output for the least input, fairness must sometimes be sacrificed. And vice versa, to get the most fair policy, efficiency must sometimes be sacrificed. This was many of the complaints surrounding the Affordable Care Act tended to focus on fairness and efficiency, with Democrats claiming the ACA helped increase fairness and Republicans saying that it actually decreased efficiency. So let's talk a little bit about fairness. We tend to see this in terms in various parts of the world. Other countries will look at what they call health insurance. In the United States, we tend to consider health insurance more as sickness insurance. What may seem like semantics actually indicates quite a bit about how Americans view sickness and insurance. So in other words, we prefer to view insurance as something you should only need in the event you get sick, whereas other countries view insurance as a tool to maintain the body's optimum performance in order to prevent illness. So many countries will prefer a primary care first system, whereas the United States, we tend to prefer a specialty-based system that ends up being very beneficial for orthopedics and other specialty medical societies. However, there are trade-offs with that. So typically the people that you see tend to be those who have broken a bone, or they have osteoporosis, osteoarthritis, things like that. Whereas in a European country that focuses on health insurance, they might be able to prevent some of those things. Another issue that we have is that Americans do not like to pay for others' risks. So I didn't just put the picture of this cigarette advertisement on here just to be funny. I wanted to illustrate this. My question is, would you want to pay for her health insurance or her child's health insurance? I mean, she is pregnant and smoking a cigarette. That's not, and the ad even draws your attention to the fact that she is pregnant. The smooth-paced, expectant mothers crave. I know I certainly would not want to pay for her health insurance. She is making a terrible choice with the information that we know now. So that's one way that we have of illustrating sort of how fairness is seen within the healthcare policymaking field. It will say the politics of healthcare spring from differing opinions on the nature of sickness itself and how society should deal with that sickness. Does sick automatically trigger mutual assistance? This manifests itself in policies like actuarial fairness, where each person would pay for his or her own risk. Shockingly, though, we have seen this change. Protections for pre-existing conditions. As an example, that your insurer cannot deny you coverage because you've had cancer or because you were diagnosed with HIV is one of the most popular aspects of the Affordable Care Act, and is actually something that AAOE, through the Advocacy Council and Board of Directors, supports. We feel that by supporting those with pre-existing conditions and maintaining that access of care, that increases the patient population for our membership. So competition in insurance brings about policies like actuarial fairness. So you've got an Aetna who wants to keep costs low and revenues high, competing with, for argument's sake, let's say there are 10 major insurers throughout the country. Now, I know that's not true, but this kind of competition creates this actuarial fairness where there is this demand for insurers to keep costs low and keep revenues high so that they can continue to remain competitive within the insurance marketplace. There's another principle that comes into this, and that's the solidarity principle. The solidarity principle is the inverse to actuarial fairness. Individual needs like healthcare are under the solidarity principle, individual needs like healthcare will be paid for by a community or group. This is manifested in mutual aid societies, fraternal associations, and government insurance programs like Medicaid. So let's take a moment and talk a little bit about efficiency as well. So efficiency is really defined as producing the most output for the least input. And I apologize to anybody that I gave a rather terrifying flashback to economics class. I didn't mean that. Um, but to determine if a policy is efficient, we must measure the cost and benefits of all outputs and select the course of action with the highest ratio of benefits to costs. But there are problems with measuring these outputs. In health policy, the biggest issue facing achieving efficiency is that we don't know what the outputs are or what the correct outputs are. So we can say that quality care would be an output, but what exactly constitutes quality care? We can use hospital readmission rates to stand in for quality, but not every procedure would lead to a hospital admission or even a hospital readmission. Additionally, comorbidities can impact hospital readmissions that the treating provider may have little or no control over. And I realize I'm preaching to the choir with some of this, but I want to provide sort of a background to this discussion. Public policy differences arise when groups or actors value these terms differently. Democrats tend to favor fairness over efficiency, while Republicans tend to favor efficiency. You can see this in the current debate surrounding healthcare financing in the United States, with Democrats favoring universal coverage and Republicans favoring more market-based approaches that they consider more efficient. As leaders in the healthcare industry, you have a unique perspective on these issues that should ultimately be shared with policymakers. So let's talk about how healthcare policy affects you. Ultimately, all of these laws that are passed affect you in some way or another. Legislation or regulation plays more of a role in your day-to-day than you may think. And healthcare is one of the most regulated industries in the United States. Since the end of World War II, regulation of healthcare has skyrocketed to the point that almost everything done in a medical practice is regulated by the government, either federal or state. Since 2001, the Centers for Medicare and Medicaid Services, which administers the Medicare program, has released 652 rules. That's an average of 38 rules a year. Now, not all of these are major rules, but they do regulate the way your physicians practice medicine and interact with patients, how you handle patient records, scheduling appointments, new service lines, the kind of electronic health record you purchase, and so on and so on. Everything that you do in your practice basically is touched by regulation or legislation. Government impacts your negotiations with insurers through the McCarran-Ferguson Act, which limits insurer antitrust laws. Your practice's compensation structures through the Stark Law are regulated. So the way that you can compensate your physicians are regulated by Congress through the Stark Law and then by CMS through regulations that are created pursuant to the Stark Law. The use of certified electronic health records technology in your practice is regulated by the Office of the National Coordinator for Health IT. If the electronic health record doesn't meet the certification standards for electronic health records technology, then you can't use it for promoting interoperability, which is the new name of the Advancing Care Information category of MIPS. So there are a lot of things that the government has its fingers in. All of these touch points then serve to make life either easier or more difficult for you. And typically, they end up making life more difficult for you. And it is precisely these touch points that makes advocacy and influence necessary. So, who influences health policy? Interest groups like AAOE and AAOS influence public policies in the United States. AAOE is very active in Washington, D.C. On the issues that matter most to members. These issues are selected through the Advocacy Council, as well as through the Board of Directors and other members of the volunteer leadership. CMS and other executive agencies influence the creation of health policy. So generally, these agencies will tell Congress what kind of authority they need to implement their policy preferences. And if Congress agrees, they will oblige CMS and provide that information. Businesses also influence health policy, whether it's through the local chamber of commerce, which would be an interest group, or the business hires its own lobbyist and works to influence policy that way. Businesses are very active in Washington, D.C. as well. And constituent and stakeholder communications have become incredibly important to influencing health policy. This is in part due to the changing technology in use by the government and organizations like AAOE to connect you with your policymakers. The old days of a lobbyist meeting with policymakers and treating them to a fancy steak dinner are over. These days, policymakers prioritize communications with constituents, making your engagement crucial to passing public policies that will make your life easier. So this is there's more of this in next month's webinar. So I would consider this as a teaser for the next webinar in this series. As a side note, if you haven't registered, head over to AAOE's site to register after this webinar. Healthcare at this moment in time is in flux. You have to share your opinions on the changes the system is undergoing. Otherwise, the changes to healthcare will not reflect your priorities. And as a member of AAOE, your priorities are our priorities. The costs of healthcare are increasing, not only for patients and payers, but the costs of providing those services are increasing. This is in part due to government policies that have made operating a medical practice too expensive. By helping to alter or repeal these policies, you can help ensure your practice's future. We'll talk a little bit more in a minute about how you can actually help increase the reimbursement for Medicare services that are provided. Third, others are doing it. Other special interests are advocating, and many of them are advocating for things that are in direct opposition to what you need or want in a public policy. A good example of this are the cuts to computed radiography. AAOE was very active on this. The radiologists were able to get a cut to CR included in an omnibus piece of legislation. And as AAOE worked to try and reverse these cuts, unfortunately, we were unsuccessful because the radiologists are so well organized, and because the radiologists actually go up and meet with their legislators and encourage legislators to prioritize their issues over others. And thirdly, I would say in a broader sense, our democratic form of government requires advocacy and engagement. Without your input, optimal public policy cannot be made. Your engagement with policymakers is necessary to ensure that the American experiment in self-government continues to be successful. So how can you affect policy? First, you can vote. It's fairly easy. Many states have voter ID laws, so as long as you have a driver's license and you've registered, you can vote. You can affect the outcome of policy at the voting booth. Now, AAOE does not tell you who to vote for, but if you look at a candidate and you look at their platform on healthcare, you should be able to make that decision on who to vote for based on your interests. Second, you can join an interest group, but I've got good news for you. You are already in an interest group. AAOE is that interest group, and we are representing you in Washington, D.C. Third, you can write your members of Congress. So anytime that you see an action alert from the Advocacy Council or myself, you can complete that action alert, you can personalize it, and you can send it on to your representative and your senators. This is one of the best ways to get in touch with your member of Congress because it's fairly simple on your part. We send you an email, you click a link, and you either personalize it or you just send it on, and it'll put all your information in there. Fourth, you can host a member of Congress at your practice. Now, this seems a little scary, but congressmen love to get out in the field and meet with their constituents at their place of business. And especially because an orthopedic practice typically holds an elevated place in the communities in which they serve, these congressmen love to be seen there. Having talked to a couple of staffers about getting members of Congress into some of these practices, I've been told, they love it when they can put on a white coat and they can look like they're actually doing something. Other associations have said if you try to put the member of Congress in as much danger as possible, make it look as dangerous as you can, they love it. They love the photo op of being there. But that's a great time to try and influence the member of Congress on a particular policy or a particular issue. And you're right there at the practice. You can show them how, interoperability is not what it needs to be for an EHR. How it takes multiple tries to get a patient record into your system, or how another system will not even send the patient record over to you because there's information blocking going on. So that's a great way to do it, and AAOE can assist you in setting this up. If you want a member to come to your practice, simply email me and let me know, and I can work with the staff to make that happen. Also, you can complete the AAOE benchmarking survey. Any survey that is sent out and receives a representative sample helps us better represent you and provide policymakers with relevant information. You can also provide data to AAOE. This is a little different from the benchmarking survey. So I'm going to take you out of here real quick and take you to our website to show you just how this works. So a little bit about the benchmarking survey. There's some information in here that we use, I won't say daily, but at least monthly, in providing information to members of Congress. And one of those is the payer mix percentage, net collections, government and workers' compensation. If it will let me access it. There we go. So you can see here we have information from member practices of AAOE on Medicare reimbursement. So we can see, if we look at the median here, that Medicare is 24% of your total revenue, or your total net collections. This is a huge bit of information for us as we go in and advocate for your practices and for you as members. Ultimately they want to know, how does this impact practices? How do these cuts impact these practices? And if we're able to say that, a 2% cut is going to lead to, 6% total cut from this 24%, that's very important for them to know. And that's very important that they understand how that impacts the practice. That it might mean you have to cut staff, or it might mean that you have to cut services, or, even trim your Medicare patient population. Anytime that the Medicare population cannot get access to service, that's a failure of the Medicare system itself. So this is very important information for us to have in our back pocket as we're trying to be your best representatives that we can be. So another way to provide data is on the AAOE website itself. So if you go to the Government Affairs tab and you go to AAOE Advocacy Efforts, you will see two things here, two menu items here. The first is the potentially misvalued codes. So every year, CMS asks organizations to submit potentially misvalued codes for review by the American Medical Association's Relative Value Unit Update Committee, also known as the RUC. Here, you can provide information on your potentially misvalued codes. So you can see if you're logged into the to your profile, it will autofill your information. And then you can put in the CPT codes that you believe to be misvalued. This is one of those things, you can get the information from your biller, your coder, anyone in your practice that is normally handling this kind of information, and you can input that information here. And then you can upload any supporting documentation, anything that shows us how the cost of providing a particular service that is described by the CPT or HCPCS code, is going to be good for us to take into CMS and say, these codes are misvalued. And those codes are more likely to be increased if that information is present. I will ask you to certify that you are not a robot submitting this information, and then you click submit and you're done. And you can do this as many times as you like. The due date is typically February 8th, but that does change every year. So please, if you have any ideas for potentially misvalued codes, we encourage you to go to this website and do this. The second one is the Quality Payment Program Measure Submission. So as I mentioned earlier, the Quality Payment Program is complex, it's complicated, and at times convoluted and contradictory. And there are many measures that do not reflect orthopedic care. The good news is we can change that. If you have improvement activities that you are doing in your practice, you can submit those here that are not a part of the sanctioned improvement activities that CMS puts out every year. Put that here, let us know what type of measure it is. Is it improvement activities? We need to change the name of this. But is it advancing care information or promoting interoperability? And then just put in the measure description and name. This, you don't have to, the improvement activities subcategory, you really don't have to worry about. This is something that we can provide to CMS. But we would like the improvement activities description. So if you were to say, provide translation services to the top foreign spoken languages in your state. Now that is not an improvement activity, that's just an expectation that CMS and HHS has as part of the ACA that you will provide those services. But as an example, if that was what you were proposing that we include as an improvement activity, then just put a brief description of what all that would entail and how we would measure that. You know, is it a yes/no answer? Are there a certain number of patients that you would need to provide that to over your total patient population? But those are great ways in which you can support AAOE and support your own practice and provide more information to us to better represent you. Let's go back to the PowerPoint. Okay, and lastly, you can visit the Capitol and meet with your legislators. Like I said, this is tied to AAOE's Capitol Hill Day, so we do want to put in a plug for that. We can also help you set this up here at AAOE. It's very easy to take part in. Our first Capitol Hill Day last year was very successful. We ended up having a lot of really great meetings and really represented the membership of AAOE well. We're looking to grow that this year. We speak best when we speak as a large group and as one. So this is a service that AAOE is bringing. There are ways to offset the costs of this. And this is something that we are happy to provide and hope that you will take advantage of. Like I said, for Capitol Hill Day, we've made it easy for you to meet with your legislators in Washington, D.C. It is a safe and effective event with which to influence policy. Your appointments are scheduled for you. Talking points are provided. Issues are selected by the Advocacy Council. In fact, we will have a meeting today where we will be selecting those issues, and training is provided in advance. So there's no reason to be hesitant. It can be a little imposing walking up to Capitol Hill and having these meetings, especially the Capitol office buildings don't seem to be the most friendly. But it really, once you get the hang of it, it's a lot of fun. You know, I've made a decision to devote my life to it, and you know, I'm naturally a pretty shy person, so if I can do it, you certainly can. And for more information, you can visit aaoe.net/hillday, or you can email or call me. My email is bcoffee@aaoe.net. My direct line here at AAOE is 317-749-0629. And if there are any questions, I am more than happy to take those now. Okay, well, if there aren't any questions, so we have a question, can I bring my physicians with me to Capitol Hill Day this year? Absolutely. This is not something that is limited to members only. Physicians are more than welcome. As we've had discussions with the Advocacy Council and among ourselves as staff, that's something that we've realized is that we cannot separate the administrative and the clinical side of orthopedics or of any of our advocacy strategies. So the clinical side is incredibly important to representing the orthopedic industry or the orthopedic sector of the healthcare industry. So absolutely, physicians are welcome. Other staff are welcome. The only thing that we ask is that they do stick to the talking points that we provide to them and advocate on the issues that we're giving them to advocate on. They can certainly bring up other issues, but we do ask that they bring those up not under the AAOE banner, but under the practice banner or under their own, as one of their own interests. But absolutely, bring physicians, staff, friends, family, anyone you like with you. Okay, well, if there aren't any other questions, I will go ahead and give you back 15 minutes in your day and hope to see you next month on the second webinar of our series. Thursday, June 21st will be our second Capitol Hill Series webinar, Why You Should Advocate. To register for AAOE's 2018 Capitol Hill Day, you can visit aaoe.net/Hill-Day. There are scholarships available. Also, I would encourage you to check out our webinar calendar on the AAOE website for more information for additional upcoming education. And please remember to take the survey that you will receive following today's webinar and look for the recording of this webinar to be available in the AAOE Live Learning Center within 1 week. For more information, please feel free to email me at bcoffee@aaoe.net. And thank you again for taking time out of your day to learn with me.